Assalamu alaikum and welcome to another episode of Chaichat, the podcast coming from Manchester. We have a lot of guests with us today. We have myself, Mahdi. We have brother Raza, who is a pharmacy graduate, but he's also training to be a doctor. We have Kazim, who is a GP, community GP, so he'll give us his perspectives on today's topic as well. And then we also have junior doctor Naqi from Manchester as well, and he'll be telling us how he's been facing the recent developments with the coronavirus. So let's get straight into today's discussion. Is everyone ready?
Assalamu alaikum. Yeah, thank you very much for having us. Looking forward to it. Of course, I'm sure everyone else will tell you that the last week or so have been very challenging, quite testing, and it's very disruptive to normal life. So it takes something that will take a while to get used to, and apparently we're not even in the thick of it yet. So it's going to be interesting listening to Naqi and Kazim just to hear what's going on in their sort of primary care, tertiary care, and sort of have a good analysis and insight into the challenges that we don't really see on mainstream news, and sort of the actual how they're feeling, because I think based on from what I've been experiencing, my work and studies, it's been quite challenging. So it's going to be quite interesting to see what they have to say as well. So thank you for joining us, guys.
Pleasure to be here.
Pleasure as always.
Obviously, we all know the rise of the virus and how it's rapidly going all around the population. Many people are being infected, and unfortunately, many people are dying from the virus as well. The good thing is that we have three medics here to talk about it, but we have different perspectives, like I said. So I want to start with Naqi today. Just now, we'll start with what it is that you're doing in your day-to-day as a junior doctor, and hopefully you can just give us an insight for the listeners to actually understand how stressful your work is right now at this crucial moment.
I think firstly, it's quite important to understand how the hospitals have changed their practice since the outbreak of coronavirus, or COVID-19, if you want to call it. The hospital has actually completely changed. The structure of the hospital has changed. The way the departments are running has completely changed, all the way from the management to cleaners in the hospital. We can talk a little bit more about how the structure of the hospital has changed. I mean, I don't want to go into it too much, but for example, if you come into hospital now, there is someone stood outside the hospital premises, and the role of that clinician is only to make sure that the patients that need to come into hospital are coming into hospital. And you'll find that 60–70% of patients are actually being turned away, okay? And they've been asked to self-isolate, or whatever they need to do, or they've been signposted in a particular direction. The hospital department itself, I mean, I am one of the A&E doctors currently working in A&E. The A&E has changed massively. We normally have three different areas within A&E. So we have resuscitation department, we have majors, and we have minors. So resuscitation is where someone needs resuscitation, they're really, really unwell. Then majors, and then minors is for more, the minor injuries and things. But now we've actually got COVID resuscitation. So we've got a whole department with 6 beds that's just for COVID patients who need resuscitation when they come in.
Sorry, I just want to interrupt. So how quick was it for the hospital to actually create this new unit? Did they have the resources to actually manage to do that as quick as they should have?
I mean, so I'm working at one of the trauma centers in Manchester, which is a really good, which is really great, because we kind of deal with stabbings and things on regular basis. We had Manchester bombing, so we had to sort of deal with that aspect of things. So we're quite used to dealing with emergencies coming in and how to change our department quite quickly. And from what I've heard, other hospitals in and around Manchester are sort of struggling with the renewing their structures of hospitals and things. So to answer your question, it was difficult, but we sort of changed. I mean, First, we changed it to something else, but we saw that it wasn't working, so we had to change it again. But this all happened in the first sort of week or so of the first sort of patient being diagnosed within the UK with the coronavirus.
Do you think the trust itself was prepared, that they had adequate plans in place to deal with a pandemic? Were the plans drawn up, and have they been executed properly? Or do you think, the Manchester's trust itself was quite unprepared, or on a national scale was enough preparation behind the scenes for this?
Raza, the honest answer is that you can never actually be fully prepared for something like this. We don't really know what's to come. We don't know where. I mean, if you take London, for example, they had 4-level plans in place, and they went from level 2 to level 4 within 1 day. So you can never really fully be prepared. However, I'd say we are, as of yet, quite well prepared. And we can go into more details a bit later on about how we are more prepared with regards to the surgeons leading the elective procedures and coming down and helping us in A&E. I mean, it has its risks and benefits on both sides and things. But I mean, to answer your question, I mean, it's really difficult to answer that question if we are actually fully prepared, but we are doing our best to prepare as much as we can.
And if it continues at the rate at which coronavirus is progressing, and obviously we've been being told that it's not even at its peak yet, we're still 2 weeks behind Italy, a couple of weeks behind London. So at what stage do you think you will really start to struggle, especially where you're working? And how has it so far impacted you and your colleagues and other members of staff around you, sort of in terms of mentally, physically? It must be very exhausting, very tiring. So how are you guys coping?
I mean, we are probably going to get very saturated with regards to beds and things quite soon. I would probably say within a week or so. And the reason why I say that is because we know that, this virus causes, it doesn't increase in a gradual way. It increases in an exponential way. And what it is that we are probably going to run out of our resources quite soon. And I think in some aspects, we probably already have started to run out of our resources. And to answer your second question with regards to pressures and things, you mentioned mentally. Yes, it has been mentally very, very draining. The last couple of days, I've been working that for 7 days in a row now. And the last couple of days have probably been one of the worst days that I've, done on A&E. And the reason for that is, you may have heard that now no family members at all are allowed to come into hospitals. So it doesn't matter how unwell your relative is. It doesn't matter if, their end of life or whatever. The relatives just are not allowed to come into hospital at all. And which sort of, it's for infection control and things, but it also, puts a lot of pressure on us, because now we have to make end of life decisions without being able to discuss it with family members and things, as we would have previously. I mean, we still try to get them as involved as possible by phone calls and, whatever else way. But it just adds another step into the whole thing. I mean, mentally, my personal life has been affected quite significantly. I mean, I've not seen my parents in over a week. I've been self-isolating, living in a hotel, just going to work from here, coming back. And the reason for that is obviously, I've diagnosed multiple people with coronavirus now, and some of them haven't done as well as others. So I'm coming across this virus day in, day out, every single day. So it's just not fair for me to go home and then spread that further. So I've I've been able to get accommodation in regards to that.
So you mentioned you mentioned that the last few days have been really tough for you, especially. And I'm sure everyone can appreciate that being a doctor, just in general, without having a huge, virus pandemic on our hands, is a very stressful job. Can you probably talk to us about your day-to-day, about what you are actually doing, the second you get into the hospital, and how different it might be to a normal working day for you?
So I spoke a little bit earlier about how the department has been split in different parts. So when we start now, we get allocated a department. in the morning or whenever we start overnight, whatever. And if it's within coronavirus or COVID resuscitation area, then obviously we'll be seeing really unwell patients coming in with, you know, respiratory symptoms, with query COVID or, you know, confirmed cases of COVID and things. I mean, normally we wouldn't have seen this many respiratory cases. I mean, in the last week or so, I've probably seen, I mean, you know, other than a couple others, I've probably seen all respiratory cases. I've seen all query COVID, you know, people are panicking. I've had a few anxious people. I mean, I'll talk about, you know, a particular example of patient, which was quite interesting. But to answer your question, I mean, normally working in a trauma center, I would have seen, you know, stabbings, dealing with minor injuries, broken hips, broken legs, you know, all that sort of stuff. I haven't seen any of that in the last, I mean, or even if I have, I've only seen it on a minimum scale in the last week or so, which changes your practice quite a bit, actually. Because as from what we understand, I mean, you know, 90% or 80% of people are actually fine, but the people who do tend to become unwell with respiratory problems do tend to become unwell quite quickly than, you know, someone coming in with a broken, you know, leg or so. And you have a little bit more time dealing with someone with a broken leg than you do with someone coming in with a respiratory problem or a, you know, chest problem and things.
And so you mentioned that you're now coming to a point where you actually have to turn down families and visitors. I want to bring Kazim into this because you're a community GP, so you interact with a lot of families, I'm assuming. So what is your opinion on the best way to handle these kind of situations where, you know, when you're dealing with end of life matters and having to put the family to a side? Is there a way where you as a doctor would have to kind of think about and handle it in a certain way?
So Naqi mentioned a very good point on when we try to make these decisions about end-of-life care and DNAR, which means do not attempt resuscitation, which is basically if somebody's heart stopped beating, whether we should be jumping on their bodies and delivering CPR. And most of these decisions, as you can imagine, are made with people with comorbidities or who are very ill. They tend to have dementia. They tend to have lack of mental capacity to make the decision themselves. And so in order to make that decision, we heavily rely on family, friends, and kin or carers to get a good idea of what the patient would have wanted. Now, specifically regarding in this clinical context of COVID, that decision-making process, as Naqi said, is an extra additional step. It has to be done not face-to-face anymore, and it has to be done over the telephone. And part of the communication skills that we learn is face-to-face interaction is, it brings different dimensions of communication, body language that you can assess, and then you can make a decision. Now, the cohort of patients we're talking about aren't really going to be the type of patients that we're going to be seeing as a video consultation. They're mostly the patients that we're going to be making these decisions on over phone calls. So that aspect of it is taken out in terms of communication. And then the aspect of face-to-face family contact is taken out. But it's quite interesting, actually. Different practices have had different ways of dealing with it. I'm on different communication groups with obviously different colleagues of mine who work in different practices. One GP practice actually took the policy where they sent an email or a letter out to all these potentially DNAR patients and basically said, from now we're going to put everyone on DNAR, and if you have any issues, you get in contact with us. So sort of putting the onus on the people. I mean, our response in the group was, that's a bit brave. It's quite
so not a bit extreme. We didn't say that's
very
a bit extreme.
I would have said that's a bit extreme, actually. But in primary care, you see practice, we're in unprecedented times, and right now there isn't clear 100% guidance. It's a lot of local led guidance and local population.
Do you not think that's poor leadership in terms of from a national level?
I think the national level,
should there not be set guidance or set best practice, which has been sort of, you know, agreed upon by sort of national experts, and then that's sort of implemented on a local level, as opposed to, each practice does what it wants or what it thinks best.
So
just
what
to add
happened in...
something in there, sorry, Kazim, before you carry on, just a very little thing. I mean, Raza talked about whether there should be something there, on a national level. The ICU, Royal College of Critical Care, what they have sort of done was they were actually going to nationally go out, and they agreed on deciding beforehand to the extent, and taking a national level, decide now whether if someone's life's actually coming to an end naturally, whether they'd want to actually spend the last few years, last few months or days in ICU. Do you actually want to be ventilated in the last so and so long, rather than or do you want to make a decision, what we call making a decision now when you're healthy, and you can actually make a decision, rather than when it comes to a point where you have to make a decision in the next hours or days or so.
Have certain decisions from families been turned down? So if a family member wanted this patient to be resuscitated, has there been doctors or officials actually been said, no, we can't do that?
Yeah, Mahdi, so it's a clinical decision. So it's a decision by a doctor. So that's the end line. However, the way we practice medicine and the way things get on, I've never ever seen a doctor make a decision on his own. And it's normally a senior clinician that makes this decision. And it almost always involves the family. It's never a decision made by a clinician on their own, but it's a decision that essentially our decision. So if we decide that they're not for resuscitation and it shouldn't happen, we can make that decision. So I've never come across it. Maybe Kazim has been practicing for a lot longer than I have, so maybe he can shine some light on whether he has experienced something like this.
So yeah, that does happen, and it gets even more trickier when you have families where divorces have happened, etc., and step members are involved, etc. I mean, it's a whole it opens a whole can of worms, really. But yes, it does happen. But the way we tackle it is clear communication, trying to get everyone on board. And as Naqi said, it's a clinical decision. Patients cannot demand treatment, but they can refuse treatment, is where the line is drawn. Regarding the question that Raza was talking about in terms of leadership from the government, I mean, you have to put it in the context. I think or not just the government, like the health minister, and also the sort of the chair of primary care. So what happened, and I think this is honestly a very, very good thing, was pretty much as soon as it became a concern in England, we had a webinar where, using obviously social media platforming, Zoom and things like that, you could connect to the webinar, which was literally from higher up down. And they were talking about specifically how primary care is going to change. And honestly, that changed overnight. The practice, I think it was Thursday, not this week, the week before, that was the first webinar, and then it's happening on a Thursday basis. So I think they're trying their best. Guidance is best, but you have to understand the situation. I mean, local, a rural area where there's not many population, where there's not many, tertiary care centers, where there's not many COVID cases, is different to us in a city like Manchester, where the challenges are massive.
Sure.
20 GP practices in like one area. So that's why you see the discrepancy in management.
And I want to understand from a primary care perspective. Are you now being called into hospitals to actually provide support? Because we all understand now that hospitals are under pressure. A lot of their staff are having to work extra hours, and a lot of them are actually falling ill. They're having to isolate themselves. So extra support is being called in. From a primary care perspective, can you just discuss that a little bit and tell us about what you've been doing?
Yeah, so regarding myself, I have 3 dimensions to the work that I do, okay? So one is like a typical GP that you see when you go to your GP practices, face-to-face clinical appointments in a normal community practice. The second aspect of my work was that I do a day or so a week in a accident and emergency department in the Manchester area. And the third aspect of my work is before all of this COVID crisis, I actually entered the field of telemedicine. So that was online consultation. So a lot of my patients are London-based, Birmingham-based. Some of them are even not even in England. Private and NHS sector. And so in the three different aspects of my medicine practice, there has been changes. Okay, so if you're asking me personally, to be honest, I was doing that anyway. So I was already going to A&Es on a weekly basis. I was already working there. I was already doing telemedicines. But there's a lot more GPs who just did, for example, just a GP face-to-face community-based practice work. And their lives are very, very, very much so different. I feel it was, for me, it was just interesting, telemedicine and working in A&E. I enjoy that. So for me, it's not changed too much, but you see, doctors are being called to help hospital colleagues out, but that's not so much primary care physicians. The way primary care physicians are being asked is, so for example, from that webinar, one of the things that came about was like any COVID cases. So we're like the gatekeepers already in the NHS. So a lot of the stuff that doesn't need to go to the hospital, like Naqi talked to you about before, there's somebody standing outside a hospital telling 60% of patients to go home. Essentially, even before that, our one of the main jobs that we try to do is prevent even then people going in to A&E, which, you know, in big cities like Manchester is not always the case because people just can't get appointments, for example. But coming back to specifically COVID related, so for example, practical example, a patient is getting symptoms, cough and a fever. And now what's happened is all primary care physicians have been asked to move to a predominantly triage-based service. So instead of going to the reception or calling your GP practice and getting an appointment straight away, what you do is you call your practice, you get a telephone appointment with a doctor who will assess your case. And if you are deemed fit enough, or for example, you're not displaying any COVID features, then you'll be asked to come to the practice where we can examine you. But if you're deemed to be at risk of having COVID, then we will ask you, we'll make a clinical judgment on how well you are. And if you're stable, we'll ask you to stay home for the next few days and self-isolate. But if you obviously become unwell, then there's two ways of it. Number one, either we'll ask you to contact 111 straight away, which is a service that the government has set up, specifically for COVID as well in this respect. And, or if you already came, like some people just walk into the practice, then we have to, there's strict procedure. We have to take you into a separate room. We have to isolate you over there. If you're unwell, we have to manage you. And then we have to ring 111 or the patient rings 111 direct. So primary care itself is changing a lot. And now I think today you guys might have read that one of the GPs, 76-year-old, was asked to come back into primary care to help provide these extra pressure services in primary care.
So is this a retired?
Yeah, this retired GP who's passed away today. And so what's actually being asked is we're asking retired GPs to come back, and we're asking, basically hospital is trying to take care of the acute side of COVID, and also discharging a lot more patients which normally wouldn't have been discharged. And from our point of view, we're getting the milder cases of COVID, trying to keep them out of hospitals. So the hospital is reserved only for the severe cases. And also managing all the rest of the stuff, you know, like what would normally be done in a hospital, like on a ward. We're trying to like sort of manage that sort of stuff. So there is pressures in that respect.
I like what you touched on in terms of the technology that's being used, especially, for example, the webinar, and then you also mentioned the telemedical services, telemedicine. So it's amazing how we're living in a time where we can actually use technology to our advantage. I mean, for example, this podcasts are supposed to be, you know, face to face, sat around the table, we're all talking, but here we are, we're doing a podcast, and it's, you know, on using technology over Zoom. So it's amazing how far we can actually go with technology to continue. We adapt to the way that we are working to continue you know, providing services. So I want to bring that on to Raza, especially, who could probably give us an insight about what it's like learning medicine now. I believe you're a couple of years away from actually graduating.
Just before you go into Raza, because I know Raza as a friend as well, and it's going to be really interesting to get his perspective on technology in medicine, especially for somebody who's coming into the field of medicine. Just wanted to make one point before that. You know, I've always been a big advocate of technology in medicine and more efficient systems and things like that. And it used to bug me before the whole crisis of COVID coming in, that why don't we use like things like you know, video consultations and things like that. And it's interesting, I was speaking to a hematology consultant who is obviously a hospital-based doctor, and he was telling me, I asked him how his medicine has changed, and he was telling me that they are obviously similar like to GPs moving a lot on telephone consultations and things. But I think it's you know, in this crisis, one of the good things that have come out of it is that people, number one, the patients are more receptive to having a video consultation. And also the GPs are, and the doctors are also becoming more, where there was hesitance before, they're becoming more receptive to actually practicing. I'll give you an example. I went to a conference in October, November, and I was talking about how I'm getting involved in telemedicine, and a lot of hesitance was happening from doctors. They were like, oh, wow, there's a big medical legal aspect of it.
Mm-hmm.
Obviously, you can't examine a patient, et cetera, et cetera. But it's something that's always interesting to me. I'll give you another practical example. Like most of my patients, as said, are in London, right? And if you can imagine myself, when I have to go see my GP, I have to wait like sometimes 30 minutes, 20 minutes past my appointment time. So when I'm ringing these patients, they're already sitting at home and I can see they're watching a movie or something, or they're just having a meal and just enjoying themselves. They're out shopping, and then they take the telephone call in a confidential area. They go there. So, you know, they're not annoyed, right?
Mm-hmm.
They're not annoyed that they had to wait so long, and it's not implementing or affecting their life. For example, I wouldn't have to take time out of work if I had to have a consultation with my GP.
Mm-hmm.
So a point I'm going to just mention, and I'm going to get Raza's perspective, is I think, you know, telemedicine is something that should have been brought in medicine way before, and now is definitely being pushed. The agenda is definitely being pushed. And I think at the end of this, I think a lot of people are going to actually see the advantages of telemedicine, patients and doctors, and it's going to be a more normal thing.
Yeah, as difficult of a time this is, I think it is also an eye opener.
Yeah.
For services like these, you know, and using technology moving forward. We're living in a technological era. So
I mean, Raza can probably tell us about, because I know you were bringing.
Yeah, I'm actually interested.
Yeah.
I want to know
how studying medicine has changed. Yeah.
Exactly. I mean, studying medicine is difficult as it is. So how has it changed in your crucial years now, before you're about to graduate? If you can just give us an insight onto that.
So I'm at a stage of my training where everything is clinical. So in terms of there's no theory that we need to learn, in terms of there's no rote learning of any foundation sort of medicine. Everything's you learn on the job, on the wards, on actual patients. So in terms of my teaching and my learning at the moment, it's all come to a halt really. I don't have any teaching going on because we don't have lectures, we don't have anything classroom based. So there's only limited scope as to what you can do now, and we're at the moment in time where the risk to medical students is deemed too high for those studies to continue. So essentially, we don't know what's happening. We're a bit in limbo.
I think, Raza, what I was reading and what I've heard as well is some final years are being asked to become.
So most med schools have actually completed their final year examination. So a lot of med schools will be fast tracking final graduation because they simply need the bodies on the front line to support people like Naqi. But I think.
Are they being trained? Are they being trained in any way to actually tackle,
no,
the
not
virus
at all.
or even
not at all.
pandemics?
So when you have your exams for finals, you are deemed to be at a competent enough level to be safe.
Mm-hmm.
So when you graduate from med school, the priority is to make sure you're a safe doctor. That is the number one priority, to make sure you don't cause any harm. So that is the actual probably from when Naqi was at medical school, Kazim was, they reiterate that time and time again that you have to be safe. and that is your paramount principle when you're practicing initially as a foundation year 1 doctor, just to be safe. So when they've completed those examinations, they're deemed to be competent to the extent that they're not going to cause harm to anyone else, but they're not deemed to be competent to have the necessary skills to help, specifically. And those are the sort of skills that you'll learn on the job. And I think a lot of stuff which foundation year doctors from final years fast tracking through can do, they can take the workload of doing a lot of sort of basic clinical procedures, which may be taking up the time of someone like Naqi or someone more, or a registrar, for example, just because they don't have the foundation year doctors in place to be able to do those jobs. So I think that's what the primary reason to fast tracking these doctors is. But I think in terms of regards to telemedicine, I think that Kazim was mentioning that, I think there has to be some sort of restraint on that as well. In terms of, you can't go all guns blazing and, have an entire shift to like technology-based medicine, because I think there's not enough evidence base to suggest that the outcomes and the safety of having consultations, over a camera is the exact same as to having consultations face to face. There are certain procedures and examinations which you cannot do over a webcam. If someone comes in with tummy pain, Kazim knows the importance of being able to feel someone's tummy, being able to carry out examinations, being able to listen to someone's chest. Those are things that you can't do over a webcam. So I think it's important, but I think there are still significant limitations. And I think in terms of having that shift, I think there has to be an air of caution. And I say that as a medical student who, has, there is technology being implemented into the medical curriculum as well. So, so there are certain things, like, for example, simulations now, which we have, we have simulated patients that are sort of controlled by robots, for example, that that you can practice on, that have clinical signs, and that you can examine on like a real patient, but they're not a real patient. So there is technology being implemented, and sort of a lot of lectures that we did have in the early stages of my medical training were done online. And so I think in that sense there is a shift now, but at the end of the day, there is nothing better than actually examining and learning on a real patient with real life signs and anything, and that's your bread and butter at the end of the day, and nothing can replace that. And I think that's why towards final year of medical school, that we simply can't continue at the moment when we don't have access to patients, when we don't have access to consultants, we don't have the time and resources to basically invest in teaching at the moment. So that's why essentially everything sort of ground to a halt.
Just going back to Raza, just another follow-on question from what you said. I think there's been quite a few very important, very good points that have been mentioned from within what you've said. So medical students, fifth years becoming junior doctors earlier than when their training would have started, would be really good from service provision point of view. And that's what we need. The more pair of hands that we have, the better it is. And talking about my hospital in particular, they've made a decision that all the surgical wards will be staffed with just a consultant and through the surgeon, and just one of the F1s, so the junior doctors, and everyone else, so all the SHOs registrars would be deployed either to ICU or A&E. But do you think in doing all this, training of medical students being compromised? So, for example, from my understand, after the finals, as you rightly said, most of the final year medical students have actually sat their exam. But you have various other things like PSA, what we call prescribing exam and things. So, do you think all this is being compromised? And do you think there's going to come a point where once we've beat COVID-19, inshallah, hopefully, that we're going to start thinking about, whether there were elements within the education that were missed, and maybe we should go back and look at them and do something about that?
So I think so this transition period, especially for final years, and speaking to a few of my colleagues, it's more of a you're sort of breaking the ice in terms of there's a lot of apprenticeships and sort of electives and shadowing which is now been cancelled. or has become totally optional. And it's sort of these periods where, as a final year, you actually learn what it means to be like an actual foundation year doctor. A majority of the people that I spoke to, and you know yourself, is a lot of what you learn and what is practically relevant now is what you learn during your first year as a foundation year doctor, as opposed to when you were a medical student. So and I think those sort of skills that you pick up, I think, are being compromised in the sense that you're just being thrown in the deep end. But I think one of the main things that unions such as the BMA are trying to stress is that you should definitely be provided with the relevant support and access to supervision that you would have, had you started normally. And it's important to make sure that you're not asked to work outside of your competency from day one. So it's about finding that, I think, that right balance, because I think at the end of the day, there is a gap to be filled, and that gap is approaching very, very soon. And you know that better than I do, being there. But it's a question about how you fill that void as safely and as competently as possible. And I think the most logical solution to that is by fast tracking final year medics.
Another aspect I want to add to that, because like my own personal experience, what you learn from experience is always is once you've gone through it, once you've seen a patient with certain disease, it sticks, and once you do like, for example, cannulation or a blood, when you actually take it, you might have learned it as a medical student so many times. But me personally, when I actually was going through F1, there's a very common saying in as doctors, which is that the learning curve is very steep, especially in the junior doctor years. Mm-hmm. This presents an unprecedented sort of challenge and also an opportunity, you see. Like, for example, me, I can't say as a junior doctor, I was faced with a pandemic in the world and I had to deal with this, the last that happened like this was in 1918, and now in 2020 we have another pandemic, and where medical training and the resilience that is gonna.
Sorry, Kazim. So were you never trained or maybe kind of like told about it and maybe had a seminar about it or something in university when you were training to be a doctor?
I mean, you see, even if you were told about sort of microbiology and stuff, I mean, if you're interested in that, or if you're interested in epidemiology, then you'd be paying, more than the minimum attention required. But it's not the most glamorous of sides to medicine, epidemiology, right? Because most of the stuff isn't about a pandemic like what we're facing now. Most of the stuff is about things that, most of the stuff is like things that happened in the past and it's not really relevant anymore. And, and it's not that interesting.
It's more of a history lesson than anything.
More of a history lesson, yeah. And it's sort of like my own opinion. Obviously, if you speak to epidemiologists, they have a completely different opinion. But anyway, I was saying that this presents an opportunity to medical students to actually get there, to learn. And there's one thing that, as junior doctors and throughout training, you get what you want from training. So, there'll be them students who will come onto the ward and they'll just want to do the minimum, and they'll just want to do, wait till 5 o'clock and go home. And then there'll be students who junior doctors who will want to stay afterwards, who will want to do the extra duties, who will want to go to, the recess in COVID. And right now we're in a, unique time where I think medical legal things, the threshold for medical legal complaints is going way down, because even the people, about medical negligence, how can you be negligent when you don't know about something? We're all trying to make the best out of the situation we can based on practice. Obviously, there's a balance of safety in that as well, which is very important. And what the point Raza made about clinical supervision will always be there, whether you're a new medical student or a junior doctor or someone, even a senior changing their field. Clinical supervision will always be there. But it presents definitely a good opportunity for resilience, for new skills, and the skills that you'll get out of this, how to face a pandemic, an emergency situation as a new junior doctor. I think is something that, medical students shouldn't just look at doom and gloom, and something they should look forward to, actually.
A recurring theme that all three of you have mentioned now is that medical staff or the NHS, let's say, require support. And we're now moving into something which has not really been seen very much ever, and that's community support towards the NHS. So there's been schemes that have been set up where you can actually volunteer to support the NHS in certain ways. And this might not be in medical, in a medical kind of perspective, but more about community perspective and how we can support community, people that are isolating themselves, the ones that are vulnerable. How can we support them? For example, myself as a normal citizen, I've got nothing to do with medicine. I've got nothing to do with hospitals or pharmacies or anything. I want to try and give my time to help someone and to see if I can do anything to make someone's life a little bit easier during this time. And it's amazing to see these kind of schemes set up now, where people can volunteer themselves. So is there anything that you guys want to say in terms of how this kind of supports your role as medical leaders within the community?
Mahdi, I think the first thing, and probably the most important thing that I will tell you and every single person who's listening to this is to self-isolate very, very strictly, very strictly. And that is the best thing that the public can do for us. Honestly, that is the best thing you can do for us. We don't care whether, I mean, we really appreciate, like you said, the support has been really overwhelming. We've had donations for food, all of the resources, everything's been there in place. But I think the only thing that we'll ask the public to do is self-isolate. And I think people have only started to, if now, they've only started to take things seriously now. And what we tried to emphasize a couple of weeks ago was that, yes, we've only got 20 cases of COVID. We only had very minimal 2 weeks ago. But what we were trying to say is, look, now is the time for you to act on this. So we see the result in 2 weeks' time. People didn't listen. People still went out. People did barbecues. The weather had been nice. People had been going out. They did all sorts. And we've seen the result of that now. We've had the most deaths in a day. We've seen the most cases diagnosed in a day. It's coming to a point where we're having to rebuild new hospitals. You've heard about the hospital being built, Nightingale, within East London. And now there are thoughts about Manchester Central Conventional Complex being turned into hospital. So, I mean, all of this is a result of the public still going out there. And believe it or not, I've been going to work, and I mean, I've been seeing people on the streets, standing there on the streets doing all sorts. And I've not, I mean, maybe they've been doing something important, but I've not been able to work out why one would have a reason to come out other than, exercise once a day. I think we probably need to become more strict with the isolation. I think the measures from the government has to be a lot stricter in order to prevent this. I think if we're not strict, things are going to get a lot worse, and NHS is going to really become quite burdened.
I mean, we are getting to a point where it's getting more strict. We're getting to a point where we've been told, don't leave the house. You can only leave for one exercise per day, or if you need to get something really essential from the shops. Do you think it will get further from where we are right now, and maybe we're being told to never leave unless it's very, very, very important? Even the one bit of exercise a day, is that essential for us right now? Could we go the step further and actually remove that?
Again, it's a very, very interesting question. And the answer is, I think we may come to that. I mean, yes, we've been, on what we call a lockdown, but even then, some of the replies that we've had from people is, you only get a £30 fine, which, most will be willing to risk. I think the measures need to be a lot stricter. I mean, if I was to go out right now, I don't think I'd have a problem with, going elsewhere, going in my car, traveling to a takeaway, traveling anywhere, walking around. I mean, I don't feel scared. I don't think I'll have any, anything. I don't think there's anything really, really stopping me from going out. And I think this is what we need. We need people to understand that, look, you may be okay, you may get mild symptoms, but that one person who may become quite unwell with what you pass on could cause a lot of damage to them.
I think what the government is trying to do is more of a trade-off, really. More of they're trying to be a bit diplomatic in the sense that, if they were to enforce a compulsory lockdown in terms of someone's mental well-being and mental sanity. You know, being asked to not leave your house for 3 weeks, I would find that very, very challenging. And especially where there's such a focus on, you know, good mental health and, you know, being proactive. And for a lot of people, exercising is that release and that sort of thing they need to do in their life to have that sort of, you know, sort of self-satisfaction. So that's why I think that it's not being as enforced as stringently yet, because the fallout from that could be massive and the repercussions of that could be massive as well.
But when we look at countries such as South Korea and even China, for example, you know, they had very little fatalities compared to the amount of cases they had. Now, we aren't seeing the same thing, and I guess the whole of Europe isn't seeing the same thing. Italy is, you know, far worse than what we are right now, but we are projected to be at where Italy is in the next couple of weeks. Spain as well has been rising. So why is it that these countries in the Far East, South Korea, China, what is it that they're doing which we aren't, and why can't we copy what they're doing essentially?
China's had multiple, if you look at the history, China's dealt with multiple epidemics. They've had multiple sort of infectious diseases that have come and gone. I think this is something that we haven't really dealt with that much in our, you know, nationally within the UK. And if you look at the measures as well, I think, I mean, if you look back in, we're talking November, October last year, October, November, December, when Wuhan first went on lockdown, I mean, all I heard from everyone within hospital, outside the hospital, friends, family was like, how can you get rid of something by putting a city on lockdown? And, you know, this was, you know, everyone was saying that globally, but China, you know, took that strict decision of doing that. And look, you're right, absolutely right. Look,
They proved it to the world that it works.
But I think there's a lot of factors in play here. It's not as simple as, you know, what the government turn around and saying everyone stay at home. I think the society allows that to happen in China, whereas I don't think the makeup of, in terms of how we live life here and sort of the cultural associations with that, I think are very different, and that needs to be taken into consideration.
Yeah, that's the point I was going to say was, you know, if you look at the West, I'm surprised. I was just reading, USA has 100,000 cases. You know, China only had 80,000. USA's crossed 100,000. Italy's got more deaths than anywhere, right? If you look at the Western or the more developed world, the first world, if you want to call it, we are used to a certain freedom and certain way of living. You know, in China, if the government tells you to do something, you do it. You don't question it, you do it, right? And over here, it's not the case, you know. And even look, you got the prime minister like literally pleading people to listen to him, and people are like still doing it. There are consequences. I mean, like even in the podcast that we did about a week ago, we were talking about where there was difference of opinion on how an isolation should be taken. I've been screaming out that we need to lock down ASAP. We need to follow China. We don't need to make the same mistakes as Italy. And Italy's been crying out to all the rest of the Western world saying, learn from us, learn from us, learn from us. And I think the point is right. You know, in UK, you know what you said, Raza, where you were saying that, you know, you would find it difficult to stay indoors for 3 weeks. I mean, I find that, you know, I understand what you're saying, but I just find that really so bizarre. The reason I find it bizarre, and let me tell you why I find that bizarre, is because I said this to friends and colleagues and patients. I said, look, if you were to stay home in human history at any time in your cave, right? This is probably the best time. Look, we're sitting here. I can see Raza, I can see yourself, I can see Naqi. You know, I can watch what I want. There's so much content. There's so much going on. We are literally living in if you want to imagine, we're living in a war right now, okay? And in World War II, if I decided, you know what, I want to go take a jog in the park, I know I'm going to get shot, right? Because that enemy I can see. Whereas the enemy now, you don't see until about a few days later. And the next thing you know, I mean, I don't want to talk about certain things more personally, but there are 30-year-olds, personal contacts. There are one of my colleagues' sister you know, I'm not going to name people and obviously talk personally, but some people have died, some people are on ventilators. And, you know, for people to start pulling out mental health right now, even though it's important, right? I think you need to, in medicine, we prioritize, you know, urgency. Right now, it's all about saving lives. We need to save your life so that you can have depression.
I mean,
But I think unless you're personally affected, like you are with your friend, your colleague, it's hard to stress the importance of it. So I think
Yeah.
prior to that actually happening, would you have taken it as seriously?
But see, like for me, it's a bit different because obviously I'm from the medical field.
Mm-hmm.
So obviously I understand.
Well, for example, your parents, you know,
Yeah,
if they've not
exactly.
seen the direct impact of it, would they, you know, just, you know?
And this is the problem. So looking at epidemiological data, you see that the Western world is way more badly affected than the Eastern, sort of Far East countries. And it's just predominantly comes down to the culture of, you know, we will not, as you mentioned, unless you see it, we will just be like, all right, Boris Johnson can say whatever he wants, but we're not, we're just going to go to the park. And it's crazy, you know, it was crazy.
I mean, it goes back to the point of adapting. You know, you guys in the medical field have had to adapt to this. I think everyone has had to adapt to this in terms of you know, staying at home and trying to keep themselves busy. Don't fall into a rut and actually, you know, destroy your mental health. You can try and keep positive in this situation.
Yeah, Mahdi, but my whole point is, you know, mental health is only going to be there if you have health. You know, if you're stuck on a ventilator, the last thing you're going to be worried about is depressed because you're not going to be awake.
There's
Yeah,
a concept
definitely.
in medicine which is called Maslow's hierarchy of needs, which basically looks at what you need to survive, and you work your way up. So having those social liberties is the final thing in the hierarchy of needs. You know, it's the last consideration. You know, having the freedom, the autonomy to go do out and satisfy your emotions, your desires. So that should be the last consideration in terms of defining what you need the most. And right at the bottom is sort of self-sustenance and the ability, you know, to safeguard your own health and well-being. And effectively, what we're doing is essentially disregarding those hierarchy of needs, and, you know, focusing on what is the least important, and, you know, disregarding everything which is, you know, is necessity and is of most value to make sure you are healthy and well. And like Kazim said, it is bizarre as well, you know.
Yeah.
But again, you know, it's down to sort of the environment we live in, and sort of how we've been brought up with the freedom and the rights of expression. And I think a lot of that plays into it.
Yeah, definitely.
As a final discussion point before we close off, I want to take it far away from medicine, and I want to put it into the perspective of ordinary people. For example, the average Joe who is who's applying for jobs, or someone who's actually working, but he's been told to sit at home now, and you know, their job is a physical job. You know, they can't really do it from being at home. What do these people now have to do? And, you know, what's in their kind of future over the next few weeks, over the next few months? Do you think there is a kind of silver lining out of this? Is there going to be a way out? You know, what's in there? Do you have any stories from friends and families that might be insightful?
Look, I'd say one thing, right? That is, like, I'll give an example of my own father. He's a self-employed, you know, person, and he's got his loans to pay. He's got his own, you know, financial commitments. But I've told him, look, listen, just stop working, all right? And why did I tell him that? Knowing that all his financial commitments and work, which I think what you're alluding to, is that, look, we will ride this out, okay? This is not something that's going to stay till the end of times, right? We will ride this out. We've had this before. We've been through pandemics worse than this before, right? And trust your body and trust nature and trust God. God has created, as Imam Ali alayhi salam says, the disease is within you, and also the cure is also within you. So just give your body that time to develop them antibodies, give the scientists the time to develop the vaccine. Once that has happened, we can get back to our normal lives, whether that is 1 month, 6 months, 1 year. Always have the end in mind, right? Because it's not forever. And also, is times are very tough. You know, I can't sit here as a doctor where we're still getting paid, talk about people who their finances are gone. I know the government's trying their best, but like for example, for self-employed people, I mean, the help is going to come in June. I mean, what are you going to do for the next 3 months? The help is coming in June, and their argument is that they're going to allow you to get universal credit. But again, that's going to happen in a few months' time. What about right now? You know, you're not making money now. So, I mean, these are where times are really tough. I think you need to speak to, you know, your financial commitments, like, you know, mortgage or your banks, and say if you can get like a mortgage, a holiday. And I think this is where the government definitely needs to help people who are self-employed, who have these problems, where the government needs to literally go to all these banking companies and loan companies and tell them, until society gets back on its feet, you need to halt or pause all payments, because once you do that, people will be more inclined to stay at home because they won't have to pay out of their pocket, right? Now, I don't think the answer is, yeah, give them more loans so that they're in more and more loan. I think that's ridiculous, personally, right? So the advice I'd give to everyone is, you know, look at your financial situation, wait it out. It will finish, you know, in a few months, in a year. It won't last forever. It's tough times, but I think the most important thing you have in your life is your life. So you have to prioritize your health.
That's yeah, very good, very good. And I think if there's no one else that wants to make any final points, I think that kind of wraps up everything I want to discuss today. Obviously, we have mentioned that it's unprecedented times. You know, it's very difficult times right now. We are being forced to stay at home. For those that are on the front line, the medics, they're doing an amazing job. And I think everyone in the UK especially are, you know, right behind the medical staff, the NHS. You know, a couple of days ago we had the kind of the appreciation for the NHS. People went outside and they were clapping at 8 o'clock. And you know, things like this, even just telling your doctor friend, you know, good job, keep it up, keeping that morale up, I think is very important at a time like this. So I want to extend my gratitude to Dr. Naqi for being in the ICUs, being in hospital every day, taking care of those patients, to Dr. Kazim, going from primary care and using his skills to support people like Naqi in hospital, and then Raza as well, inshallah, for future doctors coming forward. Hopefully we can see where they can fit in as well. And to everyone else in society, you know, for the volunteering or for the support that they put forward, especially, I think it's something that everyone needs to kind of try and get involved in, but at the same time take precautions and make sure that, you know, you are isolating if you as much as possible. And if you are feeling those symptoms, definitely stay at home, don't go out, and inshallah we'll all get through this.